In this PowerPoint, we're going to take a look at some of the advanced types of therapies in regards to positive airway pressure. Let's go to our next slide. Although we know that CPAP can be the most effective treatment for sleep apnea, what do we do when our patients simply cannot tolerate it? Typically, we troubleshoot the situation and refer back to our mask sizing and fit, or add humidity. But what if their complaint is all about the pressure? If they say that it is just too hard to exhale, or I feel like I'm working to exhale, then we need to consider some options to decrease the pressure when they exhale. Some of the options include pressure relief or switching to a bilevel therapy device such as BPAP or VPAP. Pressure relief includes C-Flex and EPR. What this does is it makes sleep therapy more comfortable by reducing the pressure at the beginning of exhalation and returning to the therapeutic pressure just before inhalation. There are actually several different types out there depending on the machine and manufacturer, but the ones we commonly see are C-Flex and EPR. Bilevel therapy can be referred to as BPAP, BiPAP, or VPAP. It depends on who the manufacturer is on how they use the terminology. If they complain of just too much pressure, one of the options they can do is switch to bilevel therapy. With this, you would want to start with an IPAP of 8 and an EPAP of 4, and then increase both sets of pressures to eliminate obstructive apneic events. If they have any other obstructive events, such as hypopneas, re-res, or snoring, you would only increase your IPAP. Another option, if they have too much pressure or if they have complaints of gastric distension, is to switch to an AutoPAP. An AutoPAP is a CPAP device that titrates the pressure automatically based on the patient's breathing. And if none of these work, there are some other options as well. On your slide here, you see there are also options of using an oral appliance with CPAP, or doing some position training with CPAP, and then also you can use ramping at the start of your night. Let's go on to our next slide. Questions to consider. Do they have complicated sleep apnea or other comorbidities which need to be considered? Is their sleep apnea position or is it REM dependent? What other positive pressure devices are available other than CPAP? And if there are, when can each be used and when can't they be used? We're going to try to answer all of these questions in this PowerPoint. APAP, which is the same as AutoPAP, may be considered if the severity of sleep apnea varies significantly throughout the night. An example of this may be when they have a lot more apneic events in REM sleep as compared to all other stages of sleep, or if they have severe sleep apnea when they're on their back as compared to their side. AutoPAP will adjust to the patient's breathing, so as they have events in different positions or different stages of sleep, it would auto-adjust to them. This should only be used on patients with uncomplicated sleep apnea. Should never be used to diagnose sleep apnea. There is a major safety issue with this type of device because if a patient has a comorbidity, it can't be predicted unless they have had their first sleep study in the sleep lab. Therefore, you never want to use an auto titration device if you have a patient with cardiovascular condition or other comorbidities. You always want to titrate those patients in the sleep lab. P95 or P90, this is where the pressure is exceeded only 5% or 10% of the time, and this is a term that they use to determine fixed CPAP pressure. Let's go on to our next slide. The current conditions are contraindications to using AutoPAP therapy: congestive heart failure or CHF, central sleep apnea or CSA, any respiratory disease, daytime hypoxemia, respiratory failure or hypoventilation syndromes, nocturnal hypoxia not related to sleep apnea, and those who do not snore. These are all contraindications to using AutoPAP. They should not have an AutoPAP titration done at home or ever. Let's go on. AutoPAP compared to CPAP has been found to have lower airway mean pressures. It has the potential for higher peak airway pressures because of mask leaks. It has similar compliance in regards to the patients as compared to CPAP. There are similar results regarding the elimination of sleep apnea and the improvement in sleepiness during the day. And it's more cost-effective than the manual laboratory CPAP titration for people with moderate to severe sleep apnea without any comorbidities. So again, AutoPAP has to be used with the uncomplicated patient, a patient with no comorbidities. Let's go on to our next slide. Other treatment options for sleep apnea include the oral devices. Compliance with these is pretty high with 50 to 90% of compliance. Some examples is the mandibular repositioner or the tongue retaining devices. These have actually been more effective than the upper airway surgical procedures that they've done. So this is a very good option. Upper airway surgery is only indicated in those with physical abnormalities responsible for the sleep apnea, and even with them the success varies. They can do a tonsillectomy and adenoidectomy, a UPPP, increased retrolingual airway, and there's a lot of different surgeries they can do with that one. Increase nasal airways. Again, there's several options they can do. They can remove polyps, they can fix the septum, and so forth. Or they could do a combination of several of the surgeries above. And probably the least popular right now is a tracheostomy. However, that is the most successful method for treating sleep apnea. Some other options are some transnasal insufflation, some oropharyngeal exercises, and there are some nasal expiratory resistance devices on the market. Let's go on. Bilevel or BiPAP or BPAP therapy is similar to CPAP. It is electrically powered. It assists ventilation through providing a pressure on inspiration and a pressure on expiration. There are two different modes. You can do spontaneous mode, and this is triggered by the patient's spontaneous breaths to switch from the IPAP pressure to the EPAP pressure. And then there's a BiPAP ST. This is flow triggered by the patient's spontaneous breath, but if the patient fails to trigger the IPAP, then it is triggered by a time interval of a set respiratory rate or I time. So this means you can have a set rate of 12. So if the patient doesn't take 12 breaths in a minute, the machine will deliver a breath. Let's go on. Indications for bilevel therapy. This is an option if CPAP fails because the patient complains that it is too difficult to breathe out against the CPAP pressure, or if the patient has problems with gastric distension. However, every option must be exhausted to trying to make it comfortable for the patient. Another option is if sleep apnea is concurrent with a restrictive lung defect or neuromuscular disorder, if the patient has obesity, hypoventilation syndrome, and persistent oxygen desaturations. Also, if the patient has sleep apnea and chronic obstructive pulmonary disease, or COPD. If the patient has central sleep apnea due to congestive heart failure, that would be an indication. If they have complex sleep apnea, this is where the patient had obstructive apnea, and then we treated them with CPAP and they developed central sleep apnea. Central sleep apnea due to medications, this would be, for example, with opioid use, and if the patient has periodic breathing. All of these are times when we could consider bilevel therapy. So let's review where we're at so far. CPAP is the #1 treatment or the first line of treatment for sleep apnea in adults. AutoPAP is comparable in results for those with uncomplicated OSA as compared to CPAP. Appropriate interface device and correct fit are necessary for good compliance. Pressure relief technology, ramping, and humidity are options to make CPAP more comfortable. You want to identify the patient's adherence to CPAP within the first few days and troubleshoot any side effects they encounter to improve their compliance and adherence. Bilevel therapy, also known as BPAP and VPAP, is a possible option for sleep apnea after all other options have been exhausted. Surgical and dental and other options exist, but careful patient selection is imperative for effectiveness, and this is not our job to select this. This is a discussion that will be had between the patient and their physician. Let's go on. So one thing before we go any further is I have to explain that based on the manufacturer, they call the same equipment two different names. So there is a lot of confusion with the terminology. Now I'm just mentioning two different companies in this one because in this area these are the two we see most often. This is not exclusive. There are other companies that provide CPAP equipment and bilevel therapy equipment, but these are the most common where I'm at, so this is the information I have. You always want to check in your area for clarification on the different devices. But we're going to go through these real quick here. For Respironics, for a patient on CPAP, they call it CPAP. This is a continuous positive airway pressure. So it is one set pressure that the patient breathes throughout the night. During inspiration and expiration, the pressure does not change. ResMed is a company that also manufactures these types of devices, and they use the same terminology. So a CPAP is a CPAP for both companies. Now, when we talk about an auto-titrating device, this is where the machine has a set pressure that it will never go below and a set pressure that it will never go above, but it will adjust pressures in between those two limits in response to the patient's airflow. So the machine's response to a decrease in airflow is to increase pressure to make sure the patient is breathing throughout the night. So Respironics calls this type of device an auto CPAP. ResMed calls this type of device an APAP. And again, this was actually an auto-titrating CPAP device. So two different companies, two different names, but both machines do the same thing. Next, we're going to talk about bilevel therapy. And we've talked about this before. This is where you have two different pressures. You have an inspiratory pressure, or an IPAP, and an expiratory pressure, which is your EPAP. These pressures change in response to flow from the patient, which triggers the machine to deliver a higher pressure on inspiration and a lower pressure on expiration. And we can set up a rate, a backup rate. So if we're concerned that the patient maybe won't take as many breaths in a minute as they need, we can set a rate of 12, and it will ensure that the patient's respiratory rate is 12 breaths per minute. Respironics calls these devices a BiPAP. ResMed calls these devices a VPAP. V stands for variable, and bi obviously stands for bilevel. Next, we have what's called an auto-titrating bilevel therapy. These machines have two pressures, an IPAP and an EPAP, and they adjust to the patient's breathing pattern automatically. These adjustments in pressure is called pressure support, and the machine makes these adjustments by measuring the breath-to-breath peak flow. As it measures the breath-to-breath peak flow, the machine averages out the peak flow according to the last 4 breaths taken. The machine then adjusts the pressure on the average of those last 4 breaths. In these modes, the machine is trying to continue a normal peak flow by adjusting both variable pressures and the overall pressure support level. Respironics calls this machine a BiPAP Auto SV. ResMed calls this machine a VPAP Adapt SV. We have one more type of machine out there. This machine has 2 different pressures, and the goal is to maintain a tidal volume and minute ventilation. These machines adjust the pressure support to maintain a goal tidal volume or minute ventilation depending on the manufacturer. So Respironics' name for this machine is an AVAPS, and ResMed's term for this machine is an IVAPS. Let's go on. So if I didn't confuse you yet, we might confuse you some more. Technically, the indications are the same for BiPAP and VPAP, BiPAP Auto SV and VPAP Adapt SV, and AVAPs or IVAPs. Now, that being said, there are times when one device is better suited for the individual. You need to consider the entire picture to make a good decision and not merely just the diagnosis. Again, you're not necessarily the person that's going to make these decisions, but it is important that you understand what each of these devices are going to do to better help the physician care for their patient. Let's go on. ASV. This is adaptive servoventilation. The two brands that we've talked about are BiPAP Auto SV or VPAP Adapt SV. With this device, the goal is to maintain normal peak flow by adjusting pressures in response to the patient's breathing pattern and peak flow. One of the key things to titrating this device is patience. The patient's breathing will adjust, but it takes a lot of time, so you don't want to be titrating too quickly. With this device, we have to let the machine do its job, and so we need to not adjust the pressure any sooner than 20 minutes apart. You just have to let the machine work. These machines measure the peak flow of the last 4 breaths. It tries to increase pressure support by adjusting the IPAP and EPAP pressures in order to maintain the peak flow of the last 4 breaths. So the pressures automatically change rather quickly, and we're watching for the patient's response to those pressure changes. As the patient takes its 5th breath, the first of the 4 breaths drops off, and then the machine adjusts to the last 4 breaths. So it's constantly re-averaging the peak flows and then adjusting to the patient. So it's adjusting rather quickly. You just don't see it. This type of device is ideal for periodic breathing, such as chain Stokes, because it self-adjusts so quickly. Let's look at an example. So in this diagram here, on the top graph, you see periodic breathing, and this looks like chain Stokes. The pink waves are the inspiratory and expiratory, and you see they're doing some waxing and waning. You see some very shallow breaths, then you see some gradually gets larger, and then it gets shallow again, and then it gets larger, and then it gets shallow, and then it gets larger. Now when they put them on the BiPAP Auto SV, now you see your pink inspiratory and expiratory, but if you look down, you see a pressure setting as well. And if you notice, the pressure increases as the patient's tidal volumes or breaths decrease. And so at the start of this titration, you see the patient takes some deep breaths, and then it starts to wane, and they start to take shallow breaths. During the shallow breaths, you see the pressure increase during those times. And then the patient continues to take some shallow breath. Eventually they take some bigger breaths. As the patient takes bigger breaths, the machine's pressure drops back down to let them breathe normally. And then notice as the machine is adjusting, look at how their breathing does improve on that second cycle. So this time they're taking slightly bigger breaths, and the pressure isn't quite as great as it was the first breathing cycle. And so then the pressure drops down as the patient's breathing normalizes again. And then on this third cycle here, you see the patient, it still decreases a little bit, but not like it had before. So as this goes on, you see why it takes a good 20 minutes to let the patient adjust. So the machine is adjusting to the patient's breathing. Let's go on to our next slide. Now here's an example of ResMed's VPAP Adapt SV. If you look starting at the left-hand side of your screen, you see the typical breathing for a central sleep apnea patient. So there's an apneic event, and then they take some nice deep breaths, and then it starts to wane again. They have another apneic event, and then they start to breathe. And then when it goes to the yellow, you see they turn the VPAP Adapt on. And you see when the patient starts to decrease in their breathing, look how quickly the VPAP adapt adjusts to it and starts to delivering a higher pressure. And then as the patient takes bigger breaths, the pressure backs off and drops back down to let the patient breathe normally. And then as the patient breathes shallow again, the VPAP adapt increases its pressure slightly, and as the patient takes more normal breath, the VPAP adapt drops back down. And then you see that their breathing just normalizes. And when you see this on a real patient, it's just amazing. But notice then the VPAP pressure remains stable, and it doesn't have to change anymore either. But it just takes a little while for it to regulate the patient's breathing, and then they breathe nice and steady all night long. Notice as soon as they took the VPAP adapt off, then the patient went right back to having the central sleep apneic events or the periodic breathing. So this is just an example of what the patient looks like before therapy is started, how quickly the therapy can work, and then what it looks like when it's removed. Let's go on to our next slide. ASV continued. So the basic indications for ASV are going to be complex sleep apnea, central sleep apnea, Cheyne-Stokes respiration or periodic breathing, restrictive lung diseases, obesity, hypoventilation, neuromuscular disorders and sleep apnea with COPD. Contraindications: some hypoventilation syndromes are not suited for this, as the gradual decrease in ventilation cannot be detected by the machines until then the patient ends up being underventilated. Since the machine is changing so quickly, it adjusts, but it doesn't adjust enough for those patients, and we'll see an example here in a little bit. Let's go on to our next slide. Okay, now we're going to talk about volume-assured pressor support. The two devices for this are AVAPs and IVAPs. The goal with this device is to maintain a target tidal volume or minute ventilation. These are ideal for neuromuscular disease patients resulting in hypoventilation and those patients with obesity hypoventilation syndrome. This is because it makes sure that that patient gets their set tidal volume or a set minute ventilation. This has a much slower reaction time because the pressure will increase over 1 minute. Let's go on. So here's an example of your patient. On this diagram, your patient's flow is on the bottom, and you see your IPAP and EPAP up above in the square. So notice your patient takes a shallow breath, and your EPAP is set at a lower level, and then it goes up to your IPAP, and then it goes on to the next breath. It doesn't really look like it changes much. And then on the next breath, it delivers a higher pressure, and finally that patient's target tidal volume is reached. So it takes longer for the patient to get to the pressure that fixes their breathing with the AVAPs because it takes a longer time to respond, but this one is based more on the tidal volume and the minute ventilation as opposed to flow. Let's go on. Here's an example of the IVAP. With this one, on your vertical column you have your breaths per minute to time. On your horizontal column, the red dots are your patient's spontaneous rate. The black dashes is what you want the patient to have. You want them to have a respiratory rate of 15. And then the blue triangles is your backup rate from your IVAPS machine. So this device maximizes the patient's opportunity to breathe spontaneously before it starts to give the patient a backup pressure. So you see the blue triangles start out at a rate of 10, and when the patient isn't taking a breath, then it kicks in and it increases with the backup rate, and then when the patient's effort comes back, you see then that pressure backs off and lets the patient breathe on their own effort. So again, this is a slower response time, but it's ensuring that the patient gets the appropriate tidal volume or minute ventilation. Let's go on. With volume-assured ventilation, the indications again are going to be hypoventilation syndromes, central sleep apnea, periodic breathing, sleep apnea with neuromuscular disorders, sleep apnea with COPD, complex sleep apnea, Cheyne-Stokes respirations, and restrictive lung disease. One contraindication is Cheyne-Stokes when it's considered to be periodic breathing. Again, it comes with careful selection. If the primary issue is a lack of muscle strength, or lung compliance, or airway resistance, which is interfering with ventilation, then the volume assured mode is a better choice than ASV. So these situations would be the better choice. Let's go on. So let's give some practice scenarios. What would happen if you're using AVAPs for a patient with periodic breathing, such as Cheyne-Stokes? Well, AVAPs is not going to respond fast enough. The event would be over before reaching the needed pressure. So in this situation, the length of the event versus the time of response you need to consider. The best solution for this patient would be auto SV because it is going to adapt quicker to these patients as they have the strange periodic breathing. Let's try another one. For a neuromuscular patient, meaning they don't have enough muscle strength when they're asleep, auto SV would continually reset the baseline and increase or worsen the hypoventilation. The normal target continues to decrease and continues to underventilate the patient as the night progresses. The best solution for these patients are AVAPs. This goes for any patient with neuromuscular disease or obesity hypoventilation, because in these situations, this type of machine, AVAPs, is going to guarantee the tidal volume or guarantee the minimum ventilation to prevent them from being underventilated. Let's try another one. So what do I need to know about all this? Because this went pretty deep and it's pretty crazy. Well, the good news is you're not expected to be competent in all of these modes right now because you're just learning. But you should have a solid understanding of CPAP, AutoPAP, and BiPAP. And when I say a solid understanding, is you should be able to tell somebody that CPAP is a constant pressure delivered during inspiration and expiration while the patient sleeps. AutoPAP is an auto-adjusting CPAP machine that will increase the pressure if the patient changes positions, and that BiPAP has 2 levels of pressure that adjusts based on the patient's flow trigger, so you should know a little bit about how they work. You should know their indications. You should know contraindications. You should know basically how to titrate according to AASM guidelines, and there was another PowerPoint for that. Remember, we don't titrate APAP because that's an auto-titrating device. You should know the limitations of each, meaning none of them will guarantee a tidal volume because that's not how they work. And then the benefits of each, why someone might want to use one device over the other. So again, your focus right now is knowing and being able to understand and work with CPAP, AutoPAP, and BiPAP, and then you have a little introduction to the different other devices. Let's go on. Things you should be able to recognize: that the following devices can also be used to treat sleep disordered breathing. Those are BiPAP, AutoSV, BPAP, AdaptSV, AVAPs, and IVAP. That manufacturers do not use the exact same terminology for similar devices, and that careful patient selection is needed to decide to use a device that adjusts pressure based on patient's flow, and devices that adjust pressure based on maintaining volumes and minute ventilation. And that concludes this PowerPoint.